Okay, can you see the current slide?
Yes.
The next one?
Yes.
Okay, recent advances in...
Yeah, but this is all in the slide sorter view, so we can't read much because, you know,
I will just change it to a full
slide presentation. Yes. Now it's turned. Yeah.
Okay.
Great.
So good afternoon to all of you, and thank you, Dr. Menu and Dr. Vedantan, for having me here to share some of my thoughts with you today. I think a lot of the points which I wanted to mention has already been discussed by Dr. Vedantan. So it is going to be, at least a part of it is going to be a revision. And we will like to look at what are the recent advances in the various mechanisms and the current understanding, and what about the biomarkers as far as this allergen immunotherapy is concerned. Of course, I would like to dedicate this talk to my teacher and mentor, Professor Ravindran from Trivandrum Medical College, where I did my post-graduation. We lost him last year. And he was the main motivating factor for me to take up research as well as to take up the field of allergy.
I went for a conference to Trivandrum, and we also invited him to PGI for...
Yeah. He was one of the doyens. I think he started in 1960s.
Yeah.
And in Trivandrum Medical College, the waiting period for allergen immunotherapy, which was given free, of course, we used to train 3 states, and the waiting period was 2 years.
Oh my God.
Yeah, it was a very... So he had, I think, one of the doyens in the field in the, South India. And of course, this is the beautiful city of Mysore, where I'm from. And the famous festival during the Navaratri.
Yeah.
And the mechanisms, as Dr. Vedantan has already discussed, it is quite complex. But the main thing to understand is there is no other treatment, including steroids, that has such a wide array of the benefits. As we shall see, there is no other treatment that can have so much of benefit. It encompasses a wide variety of immune responses. You have humoral responses, you have cellular, and more than 40 different mechanisms have been described, and more are coming out every year or 2 years. What I thought for the beginners is an ideal way, if you want to look at the pathways. Before that, you need to understand what are these various cytokines. And unless you actually understand, the pathways will always be a little difficult to grasp. So this is just like a glossary first. We will go through what each of these does. And then when we see the pathways, it will make more sense. So you will find in all these pathways, you will find IL-4. So what does IL-4 do? It promotes Th2 differentiation. A very important action is the B cells that when we are exposed to any protein or a glycoprotein, when you produce IgM and IgG, that's your normal behavior, immune behavior, these B cells now start producing IgE to those particular proteins. Now this is dealt by IL-4. It also increases the secretion of various chemokines from the airway epithelium. So this is what, in just very small, what the IL-4 can do, and every time you see this in the pathway, this is what you need to understand. What does IL-5 do? IL-5 is mainly associated with eosinophils. It is relevant for the migration from the blood to the tissues, for the further maturation. It's also important for the survival. Once the eosinophils are under the influence of IL-5, they survive for a very long time. Now that's what IL-5 does. So if you want to look at eosinophils, IL-5 is your important cytokine that deals with that. And therefore, anti-IL-5 mainly deals with asthma, where you find eosinophils to be a very dominant factor. Now, IL-13 is always associated or closely associated with IL-4. Now, what does this do? It is known to promote airway inflammation. It causes mucus hypersecretion. You will find some of the asthmatics, they say, they produce a lot of mucus compared to others. Steroids, unfortunately, don't work very well. We have struggled for years to have these patients come and tell us that they don't have any sputum production anymore. But only after 1 or 2 years of immunotherapy, you will find that these people respond. They don't do very well with steroids also. It also causes subepithelial fibrosis. Means it is one of the important mediators as far as airway remodeling is concerned. When there is an airway remodeling, asthma behaves like COPD. It doesn't respond to any of the steroids or any of your bronchodilators. Patients continue to be symptomatic. So airway remodeling in asthma is every clinician's nightmare, because patients expect to get better after coming to you, but they don't. They continue to be symptomatic. That's going to be a big problem. And the BOLD study, of which I was one of the parts, it's been done in more than 60 countries for COPD, found that after tobacco smoking, the most common risk factor for COPD is asthma. And IL-13 has a major role to play. We also have anti-IL-13 biologicals now. Now IL-13 also influences these eosinophils, and it secretes eotaxin, that brings in more of eosinophils into the tissue. It also makes the airways more hyperresponsive. So this is in just the functions of what it does in the asthmatic scenario. Now if you look at IL-9, now this is a T cell and a mast cell growth factor. It also leads to airway hyperresponsiveness. It also leads to increased IgE. It also leads to mucus hypersecretion. Again, it is not one of those where you respond very well to steroids. Now we come to IL-17. Now these are produced by the TS17 cells and the innate lymphoid cell too. ILC2 is an innate lymphoid cell too. Now these recruit the neutrophils into the airways. So you have IL-17 dominant asthma. Now these patients have more neutrophilic asthma. The problem is, if you have eosinophils, they are steroid responsive. If you have neutrophils, you know they don't respond to steroids. Now this does lead to steroid insensitivity. If you have TH17, IL-17 dominant asthma, it is not going to respond to steroids at all. It leads to airway remodeling. It leads to mucin hypersecretion. Now some of this neutrophilic asthma can be reversible. It is a eosinophilic asthma which has turned neutrophilic due to the exposure. So what are these exposures? Ambient air pollution is one of the factors. Hidden indoor exposures. For example, people don't realize that if you run a mosquito coil for 6 hours, it's like burning about 100 cigarettes. If you burn an incense stick in the house, depending upon the length and width, it is equal to burning 5 to 15 cigarettes. If you burn the dhoop stick, it is equal to burning about 1,000 cigarettes. There could be passive smoking at home, or this adolescent child could be a smoker. So these are all the factors where an eosinophilic asthma becomes a neutrophilic asthma and does not respond to steroids. So every patient you meet, you must ask for these exposures. And you will find suddenly a patient who has not responded to treatment you may find that if you avoid this exposure, suddenly becomes treatment responsive. That's because the IL-17 has reduced. When you avoid these exposures, less of neutrophils come in, and then they do respond to treatment. Now, whatever IL-25, again, it leads to airway remodeling. It is produced by the airway epithelial cell. It is one of the group of cytokines called as alarmins. And of course, it promotes the Th2 cytokines as well as the Th2 deviation. Not able to switch the slide. Not able to switch slide. Okay. Next you have IL-33. Now, along with IL-25, this belongs to the group called as alarmins. We thought for a long time airway epithelium is just a barrier. It is not. It is very, very active. It secretes a huge amount of these various cytokines, and IL-25, IL-33, and TSLP, these are very, very critical in the pathogenesis of asthma as well as the response to immunotherapy. Now, IL-33, it promotes Th2 differentiation, and this is independent of IL-4. STAT6 and GATA3 are transcription factors. IL-33 also increases IL-5 and IL-13 production. It is a chemoattractant for Th2 cells. It also increases eosinophil survival. It leads to maturation of mast cells, airway remodeling, steroid resistance. So you can look at how many of these cytokines are associated with steroid resistance. And you will find that over a period of time, of course, we have now been practicing after our PG for about 25 years now. And while it just took about 200 microgram of budesonide to control most patients, 200 to 400, in 2000, we are struggling in 2022 with 1,600 micrograms, LAMA, xanthines and systemic bronchodilators, and we are still struggling to control the asthma. We look at TSLP. Now that's a very, very important cytokine. It has its own biological now, launched commercially this year, and it increases in the antigen presenting cell, promoting the Th2 pathway. It also induces Th9, Th17 differentiation, airway remodeling. It regulates ILC2 and suppression of Treg cells. Want to look at IL-6? Again, it is produced by the epithelial cells, also by macrophages and other inflammatory cells. It can increase on exposure to allergens, respiratory syncytial virus as well as pollutants. It also promotes Th2 differentiation, inhibits Th1 differentiation, mucus production, matrix deposition, protease release from granulocytes. These are all the effects of IL-6. It is also increased in obesity-associated asthma, and again, less responsive to steroids. IL-2, T-cell activation, it is relevant for non-allergic asthma. Reduced steroid responsiveness is there. It increases the glucocorticoid receptor beta subunit. For a steroid to act, it has to reach the glucocorticoid responsive element in the nucleus, in the DNA. But what is an active form, like how you have your antihistamines, you have two forms of the receptors. Alpha is good, it binds to the steroid, and then when it binds to the DNA, there is a functional response. But if the steroid binds to the glucocorticoid beta receptor, it is not even going to go into the nucleus, and it's not going to be effective. Now TGF-beta, from the macrophages, epithelial cells, eosinophils, it is pro-fibrotic. It promotes type 1 and type 3 collagen in the subepithelial region associated with thereby remodeling. TGF-beta is not responsive to steroids. Look at IL-10 is one of the good ones. Comes from Treg cells as well as dendritic cells. It is very potent anti-inflammatory as well as an immunosuppressive cytokine. And IL-10 is increased when you use steroids as well as when you use the allergen immunotherapy. Now, your gamma interferon, it's a cytokine required for innate, both innate as well as adaptive. It counter-regulates IL-4 associated with neutrophilic asthma and steroid resistance. So here, you start getting confused. This is a Th1 cytokine. It is supposed to counteract Th2. And then we are also telling that gamma interferon is causing neutrophilic asthma and associated with steroid resistance. That's because now with the precision medicine and looking at different subgroups of asthma, we not only have T2 high asthma, we have T2 low asthma, we also have Th1 asthma, we also have mixed asthma. So while in certain situations gamma interferon is good, it counteracts the deleterious effects of Th2 cells, in certain scenarios this itself can be responsible for something called as Th1 asthma as well. Now IL-12 mainly comes from the dendritic cells. Again, like IL-10 is one of the good ones. It reduces the allergic inflammation. It controls the antigen-driven Th2 as well as Th17 responses. Now IL-22, it is from the T cell as well as innate lymphoid cell. Again, it has a dual action. Along with IL-17, it is pro-inflammatory. But in the milieu with the absence of IL-17, it is an anti-inflammatory. So depending upon the surrounding milieu and the concentration of the cytokines, it can be good, it can be bad. If you look at IL-11, it is also secreted from the epithelium. It is also pro-fibrotic along with TGF-beta as well as IL-17, but it is steroid responsive. Now, I'm not going to go into too much of these here, except to know that you have a wide number of transcription factors, which are very, very important. And these secretions of various anti-inflammatory proteins. Now, this is a particular receptor that is associated with the lipoxin and the innate lymphoid cell too. Various mechanisms of actions of this, we all heard about programmed cell death as far as cancers are concerned. They are also important as far as allergen immunotherapy is concerned. Now, this is a cell surface receptor. It is going to downregulate the immune system and suppresses the inflammatory T cell activation. And the PD-1 immune checkpoint serves a dual role in promoting apoptosis in antigen-specific T cells, while simultaneously reducing apoptosis in good regulatory T cells. So PD-1 is one of the more recent effects of allergen immunotherapy of how it acts. We will look at how it acts in one of the subsequent pathways. Now Treg cells themselves are now of various different forms, and you will find in the newer, the recent articles, you will find a natural Treg cells that will exert their suppressive capacity in a direct cell-to-cell contact dependent manner. It will act by the CTLA pathway as well as the PD-1 pathway. You also have an inducible Treg cell which acts distantly. It acts via IL-10. It suppresses Th2. It also increases local IgA. IL-27, of course, is secreted from the dendritic cells. It downregulates the Th2 responses. It is also one of the good ones like the IL-10. Now IL-21, it is upregulated in the Th2 and Th17 subsets as well as the follicular T cells. It induces cell division and proliferation of various cells of the immune system. Now, Treg cells, we have already realized that there are multiple varieties of these, and the IL-35 is again one of the very important cytokines that has now come to light. It is one of the good ones. It reduces both eosinophils and neutrophils in the lungs, and it generates its own unique class of regulatory T cells called inducible Treg 35 cells. Now, these are different from the other Treg cells. Now, we start looking at now we'll go into the different pathways and then see what this can do. If you look at the normal person who is genetically predisposed to the allergens, on exposure to the allergens, especially the first time, you have dendritic cells with about 2 or 3 of these actually you will find about 2 or 3 of these pseudopodia from the dendritic cell sampling the airway lumen, and on exposure to the allergens. Now you have we will look at in the next slide that these dendritic cells interact with the T cells using different language, like how we use Kannada, Malayalam, Tamil, Hindi, Punjabi. These cells also use several languages to interact with the T cell. And depending upon that language, we either go on a Th1 dependent pathway and produce IgM and G, or move towards the Th2 pathway producing IgE. So this interaction and if this language leads to the Th2 pathway, now these T cells will start producing IL-4, and IL-4, as we have seen, what it does, it increases the Th2. There is an auto-stimulatory mechanism from the Th2 as well as the airway epithelial cells. You have these alarmins. They interact with the innate lymphoid cell 2. IL-5 is going to come from all of these. IL-9 is going to go back to the epithelium and increases the mucus production, damages the epithelium, whereas the IL-5 will move into the eosinophils. The IL-4 and 13 will also act on the B cell. We have seen the IgE class switch, and once there is a class switch, we start producing IgE, which now sit on the mast cell, the eosinophil, as well as the basophils. Now, IL-13 as well as the GM-CSF also has a role in these effector cells. If you want to look at an eosinophilic airway inflammation, they are not only allergic, we can get an eosinophilic inflammation via a non-allergic pathway also. So not every patient with eosinophilia may be a candidate for allergen immunotherapy. You can know that it can be due to pollutants or even microbes or glycolipids. Actually, on the exposure to the epithelium, these are the main cytokines. Now, via the CRTH2 pathway and PGD2, that is the prostaglandin D2, binds to this receptor. Again, from the innate lymphoid cells, we do have IL-5, IL-13, all causing eosinophilic inflammation. If you look at the subsequent exposure to the allergens, now these allergen IgE complexes, you need at least 2 of the IgE molecules close to one another to actually bind with the allergen. These are all the different cytokines, these are all the different cells, and every one of these cells, allergen immunotherapy has been shown to be beneficial. They can be classified into 3 main groups. Its mechanisms of actions. One, of course, is the upregulation of the Th1 cytokines, They are gamma interferon, IL-12, IL-2, down-regulation of the Th2, mainly the IL-4, IL-5, IL-13, upregulation of Treg cells, IL-10, and Th3 also produces TGF-beta. So TGF-beta is good in some situations, is bad in some situations. This is, I think Dr. Vedanthan has already dealt with, so I'm not going to go into the details of these, looking at the timing of the action, looking at the various immune mechanisms, including the blocking antibodies. This was actually described in about 1935 by Robert Cook, and it is still stood the test of time and is one of the main mechanisms of actions. But now we do know a lot more. So this is a slide showing you the summary of all the effects of how an immunotherapy can act. On the Treg cells, it increases the IL-10. If you look at these numbers of eosinophils and mast cells, they are less in the tissues, and those that are there releases less mediators. If you look at Th2, there is a decrease in the allergen-specific proliferation because we are exposed to allergens possibly every breath. And some places more, some places less, but every breath you may be exposed. Now, every time you are exposed, there is a continuous stimulation and more production of these Th2 cells. Now, what the allergen immunotherapy does is decrease this allergen-specific proliferation, decreases the number of these in the late phase reactions, decreases the mediators that are released from these, increases, of course, the Th1 mediators, as well as increase in the regulatory T cell. In the B cells, it reduces allergen-specific IgE, it reduces seasonal increases in IgE, it increases IgE-facilitated antigen presentation, it increases in blocking antibodies as well. Ultimately, it leads to improved quality of life, decreased symptoms and drug usage, allergen challenge test Dr. Vedanthan was talking about will be reduced early and late phase reactions to allergens, decreased skin test reactivity, decrease in the prevention in the progression of disease, as well as prevention of newer sensitization. These are all the clinical effects, and these are all the immunologic markers for these. Now, almost all the mediators that we have just discussed, allergen immunotherapy has benefit. There are also other newer mechanisms. For example, if you look at the effect on the endothelial cells, after receiving allergen immunotherapy, because of the changes in the ICAM and VCAM, less of cells from the blood will enter into the tissues. So that's a key mechanisms of allergen immunotherapy. If we have looked at so many different pathways, allergen immunotherapy reduces tissue remodeling. So many of these cytokines you have realized as an effect on the tissue remodeling, and the immunotherapy, whether it is subcutaneous or whether it is sublingual, has an effect on all these different cytokines and has a beneficial effect on reducing tissue remodeling. Interestingly, you will find that none of the steroids can act on the dendritic cells. Immunotherapy can act. It suppresses, again, dendritic cells can be harmful, they can be good. So the inflammatory dendritic cells are suppressed, the tolerogenic dendritic cells are increased. That's what immunotherapy does. If you look at the effect on the Th17, Th9, these are neutrophilic asthma. Immunotherapy has also, because of its effect on the Treg cells, has an effect on the cytokine of Th9 and Th17, and therefore where no steroid can act, there is no drug we have currently that can act on neutrophilic asthma. And you will find patients have partial to no relief. Sputum induction, you will find neutrophils. Antibiotics, there is no response. Probably they say you can go on long-term macrolide therapy for these patients. Immunotherapy can help because of its effect on the Th9, Th17. Now, this also modulates Th1. So now we know that Th1 also, Th1 asthma itself is an entirely separate entity. We still don't know much about it, but you find all the recent, starting from about 2019, you start seeing the Th1 asthma as well. Now, Th1 asthma also, immunotherapy has some benefits. The main effect of all these is due to the effect on the T regulatory cells. Now, the T regulatory cells results in the tolerance or energy of the antigen-specific T cells. There is an immune deviation of the allergic-specific T cell response from Th2 to Th1 pattern. Now, effect on the IL-10 on the Treg cell itself. Now, Treg cell also produces IL-10. Now, the dendritic cell, effect of the dendritic cell on the Treg cell via IL-10 is a new pathway. Of course, there is IL-12 also is a new pathway. So these are all more recent mechanisms where it is shown to be effective. And what happens is when you have an IgE, the IgE we know sits on the mast cells and the basophils. The IgE also sits on the antigen presenting cells. And with IgE sitting on the antigen presenting cell, the language is different. The language is more towards inflammation. Now, immunotherapy also inhibits this IgE facilitated allergen presentation and interaction between the antigen presenting cell and the T lymphocytes. Now, the newer mechanisms of this allergen immunotherapy includes, now we know there are so many different types of T regulatory cells. We talked about the peripheral Treg cells, molecular T cells, the inducible Treg cell 35. You also have the dendritic regulatory cells, you have the B cell regulatory, and these are some of the several mechanisms by which immunotherapy can help. Now, if you look at some of the newer pathways, now the PDL1 is by a cell-to-cell contact. The apoptosis of the inflammatory cells and the reduced apoptosis of the tolerogenic cells. That's one of the main mechanisms of action. Cell-to-cell contact is needed. When we talk, we also have now ILC3 and the CD40 ligand driven pathways. You also have some of the newer cytokines, and again, this is how the allergen immunotherapy acts. We have IL-27, which we discussed in the glossary slides. They are also important. So newer and newer mechanisms are now coming in when we talk of an allergen immunotherapy. Of course, the Treg, the natural Treg, the follicular T cells are all important. So the allergen immunotherapy induces the Treg cells, regulatory B cells, regulatory dendritic cells. And again, there is a host of these effects. There is also inhibition of the Th2 cell associated phenomenon, such as the mucus production. All these we have already discussed in the previous slides. Just a summary. The mucus production, because we have seen some of these patients, they don't respond to anything. Now, after immunotherapy, we have seen it takes a long time, 1 year, 2 years. Most of these people have now responded and they say, now I don't have any sputum anymore. Otherwise, every month they come and say, I have increased sputum production. That doesn't respond to any treatment. Now this, of course, is the suppression by the cell-to-cell contact. We talked about PD-1, we have seen in the previous slide. Now we are also seeing about the cytotoxic lymphocyte-associated protein 4. Now, these are the two mechanisms by which there is a suppression of all the inflammatory cells. Now, the Treg cells, via the cell-to-cell contact mechanism, is going to work with all the different inflammatory cells. And you have natural killer reg cells also, ILC reg cells also. And these are also affected by the allergen-specific immunotherapy. So you have a host of regulatory cells. For a long time, we only talked of Treg. Now we know that every one of these cells also has a regulatory component, and all of these are influenced by allergen immunotherapy. All of these. So quickly, let us look at again biomarkers. Dr. Vedanthan has already spent time, and I will go through that quickly. And how are these biomarkers used? That specific Ig, total Ig, the ratios. Are they useful for monitoring of the efficacy or clinical efficacy or just immune monitoring? And then what are the effects? A transient increase in serum Ig, a specific Ig, followed by blunting of the seasonal increase is what you are going to see with immunotherapy. But some studies show an increase in the total Ig, whereas some shows decrease or no change. If you look at the ratio, a cutoff value of 16.2% specific Ig versus total Ig ratio was effective in predicting the successful outcome of AIT. If you look at IgG4, a 10 to 100-fold increase in the concentration, it is correlated with positive or good clinical outcomes. If you look at specific IgG A1 and A2, both of these are increased, and that is good because they're also like IgG kind of a blocking antibody. If you look at basophil activation and histamine and other mediator release, suppression in basophil activation has been shown. If you look at IgE-FAB, now that is a test to measure the blocking IgG for antibodies. But these are correlated with clinical symptoms. If you look at DC-REG, you find upregulated DC-REG components following sublingual immunotherapy. ILC-10, induction of the cellular responses with ILC-10 has been shown for grass pollen as well as dust mites. If you look at Th2 cells, reduction in Th2 cytokines have been shown. So if you look at Treg cells, induction of the functional, natural FOXP3 Treg cells as well as inducible Treg cells have been shown. If you look at Breg cells, again they are elevated following the house dust mite grass immunotherapy. So to summarize, the immunological mechanisms of allergen immunotherapy is complex and the understanding is still evolving. The spectrum of benefits is far superior to that of any pharmacotherapy, including steroids. And the benefits extend to very difficult to control symptoms and changes such as mucus hypersecretors and airway remodeling. Some benefits in neutrophilic airway inflammation also can be expected. Th1 asthma as well. The only known treatment that can alter the natural history of allergic diseases, it is far more effective and economical than any known biological. I have hardly used any biological because 2 months of biological is my 5 years of slit. So obviously it doesn't make any sense for me or for the patient to use the biologicals. And they have far more effective. So this was my initial talk. I don't know if there is more time or you would want to go for discussion.
Thank you. Thank you very much, Dr. Mahesh.